I don't have any acknowledgments relevant to this presentation. I think there's been some recent evidence that the worse your damage in your eye, the lower your quality of life, and the more that this changes over time as well. So I think this is something which is inherently obvious to all of us. But I think quality of life is a very complex topic, and I think we are best describing it in ways that are most relevant to the patient so we can understand that. And I think this is not just important in terms of a scientific sense, but it's also a real pillar of the advocacy work that we do. So ultimately, it's our job here to advocate to funding agencies, to agencies that might support patient care, that might grant us more resources, and certainly understanding what the disease does to the individual in common sense terms is an important supplement to the political efforts and the regulatory maneuvering that we need to accomplish. So what is something that is a common sense metric? I think it's something that you can describe to your mother, and they would understand what she would understand what you're saying. So this might relate to things such as whether you can read and how quickly you can read, whether you must stop driving, whether you're stuck in the home, whether you fall, and whether you do less physical activity. And we'll talk about some of these today. I think reading is something which we don't often think about as being affected by glaucoma, even though that many patients complain about it. So it's over 40%. And people have shown that if you decrease the contrast of the text, it's particularly difficult. Although, frankly, we often read text that is very high contrast, except when we're maybe outside reading street signs and other things. Anant Viswanathan has suggested that people have more trouble finding the next line of text. And George Spaeth has a set of activities that he had his patients do, and he found that reading small print was the most effective task in this set of activities. We had a population-based study in which we identified individuals with glaucoma who were older, and we had them read 6th grade texts at 4 different text sizes with their normal glasses for 15 seconds, and they had to read aloud. And what we found was that only patients with the most advanced disease demonstrated slower reading. So if you had glaucoma that was manifest in one eye or both eyes, you read just a small bit slower. The average individual read about 150 words per minute, and so it was a very modest change until you had very severe disease in both eyes. But at this point in time, it was a question of really whether it was your field of vision or just the fact that the disease was so poor that it affected your visual acuity. This didn't really seem to make sense, given the fact that there were lots of complaints of this in our clinics. And even, in fact, a lot of patients who didn't have very advanced disease had these complaints about reading. But they never said that they had trouble reading just for a short time. They always said that they had difficulty when they had to read a book or if they were still working to continue that work over many, many hours. And so we said, well, why don't we actually test them reading something that they might normally read? And so we wanted to create something which was done, instead of being done out loud, was done silently. We had to ask, what would we have them read? And so for the reasons that I'll show you below, we actually had one of our students write a 7,300-word story. We measured the speed by looking at when they turned the pages. We realized that our patients might have very different educational levels, and so we made all the pages very simple. And we had to find out if they were really reading and understanding the material, and so we actually had them answer some very simple questions afterwards, just so that they would pay attention. This is kind of how the test ran. Every page they turned, we timed the beginning and end time, and depending on how long it took, since each page had 200 words, if it took a minute to read, we knew they read 200 words per minute. If they read a page slower, it was a little bit slower. And what we found is that there was a much stronger effect on silent reading than on out loud reading. So if you looked at silent reading, the effect of glaucoma was about 30 words per minute, which was much more substantial as compared to out loud reading, which was, again, only about 13 words per minute. And in fact, everything that affected reading affected silent reading much more than it affected out loud reading. You can ask, well, why is this? Well, I think when you read out loud, you'll only read as fast as you will talk. And you will only talk as fast as you're comfortable and other people will understand. So in fact, we don't talk as quickly as we can process information. And so, in fact, when you read as quickly as you can process the information, so it challenges you just a little bit more. We found that several word features were particularly relevant to reading speed. So people who had worse contrast took longer to read each word. And this was particularly true when the word was longer, when the word was on the first line of the text, and when the word was more complex through use in language. And in fact, what we think is happening in reading is that you spend enough time on each word to make a good educated guess about what you think that word is. I think when you have glaucoma, you might cheat a little bit. You might say, well, I think I know what that word is. But when all of a sudden that word is more challenging, when the word is longer and you don't see as much of it, or when it requires you to move to a next line, or it's a rarely used word, that you have to spend just a little bit of extra time than even a normal person would. We also found that people seem to fatigue when they read. If you look at a normal individual shown in red here, each of those little dots depicts how fast they were reading over a 30-minute reading time period. And you can see that they started reading around 200 words per minute, and it didn't slow down very much over the course of the 30-minute reading period. However, if you had glaucoma, and these are comparable individuals at the midpoint of the groups, they started reading slower, but they seemed to slow down with time. And in fact, we found that slowing down was more common in glaucoma, that they slowed down about 4 words per minute every 10 minutes, and about half of them demonstrated slower reading over time as compared to about a quarter of the normal individuals. I think a second area that, especially in maybe not so much in Hong Kong, but especially in the US that we deal with is driving, because driving is so critical to our independence. People who stop driving more likely to become depressed and enter into long-term care. It is, unfortunately, still our primary mode of transportation, and it's very highly valued in our visually impaired patients. We found that in the Salisbury Eye evaluation that the probability of having to stop driving went from about 20% in people who didn't have any visual field loss to almost 75% in people who had very severe loss. And if you had glaucoma in both eyes, you were about 2.5 times as likely to have stopped driving. And in fact, 1% of the entire older population had stopped driving as a result of their glaucoma. So the population-based impact was quite large. You could say, well, how much of this impact is really, or how big is this impact? Well, you can compare it to other things. So you can say that, if you had a 5-point drop in your mini-mental scale, that takes somebody from being essentially cognitively normal to having mild cognitive impairment. That's about the impact that glaucoma does. So it's a very substantial impact in terms of stopping driving. We thought also that if people had stopped driving, that they might actually leave their home less, that they might have what we call a smaller life space in the scientific community. And this is really important. People who restrict themselves to the home have a higher mortality. They are more likely to go on to Alzheimer's and cognitive decline. They're more likely to become frail. We wanted to measure this directly, and so we got a cellular tracking device that was actually marketed for monitoring a child that might be doing the wrong thing, or a spouse that might be cheating on you. And it tracked where people went every 15 minutes over the daytime, and it looked at how many times they left their home, and it was very, very good in terms of how it worked. And we found that people who had glaucoma were about twice as likely not to leave their home on a given day, and it was really the only thing that was significant in this study. One very interesting thing is that if you look at the impact of disease, it was quite substantial, and severity of disease. But the other thing we looked at was whether maybe medications might have an effect. So is it our treatment of people that might be making things worse? And what was very interesting is that we found that actually disease was not the strongest predictor, but actually one medication that we used to treat the disease. So alpha agonists had about a 4.5-fold risk of people not leaving the home. And I didn't know whether this was some sort of selection bias or something that maybe we just treated people who were sicker with this disease. But in fact, if you start going back and asking patients about whether this medication makes them sleepy, you start hearing a lot of positive responses that it does. And it actually seemed to have very substantial real-world implications for how people behaved in their daily life. We've been following a lot on the idea that people might restrict their travel outside the home because they've either had a fall or they're fearful of falling. And in fact, asking people about previous falls have demonstrated about a 2- to 4-fold risk of falls. In the Salisbury Eye evaluation, they found that peripheral loss and not central loss was actually the primary risk factor for falls. And a study done in Australia by Joanne Wood and Alex Black found that 1 in 3 glaucoma patients injure themselves from a fall in a given year. So it's very, very common. It's a significant public health issue. It's the leading cause of accidental death in older adults, 3 times as common as deaths from automobile accidents. 80% of injury-related hospitalizations are from falls, and in fact, if you see your patient come in with a bandage or a splint or a cast, it's almost a certainty that it happened because they fell. The costs of this are astronomical. It's about $55 billion projected in 2020. Simply being fearful of falling is also very problematic as well. It makes people restrict their activity, lose their independence, become less socially active, and lose their mood as well. We actually looked at this in a Roche analytic model that I won't describe too much. It actually describes not only the complexity and difficulty of the task, but also where people lie along this scale. And it describes in units of logits, or log odds units, how much difficulty people have with fear of falling. And we found that there was a very substantial effect. And again, you can calibrate this effect by understanding what are the impacts of other variables in the model. So for example, somebody who had a comorbid illness known to affect mobility had about a 0.53 log odds lower score. But this was equivalent to the impact of 5 decibels of worsening. And in fact, our average individual with glaucoma in the study had about a 1.2 log odds lowering, so about 2.5 times as great as having another illness. We really wanted to go on and look at whether maybe because of all these issues, people also restricted their physical activity, which is, of course, a really central element of health. People who are less active have a higher mortality. They have numerous other diseases, heart disease, diabetes, osteoporosis, and lower quality of life. We measure this with accelerometers, which I think are becoming very common for even just social use. It calculates not only steps, but the intensity of the time you spend. It's very highly correlated with gold standard measurements of energy expenditure. And it's much more related to body mass index, blood glucose, skin fold thickness than what people report as their activity. And we found that people who had visual field loss in the population did about 30% less physical activity. And again, this was very comparable to many other substantially impactful conditions, greater than arthritis and diabetes, and a bit less than congestive heart failure or stroke. People, as they had more and more disease, actually took fewer steps per day. And I think we've now started looking the other direction. We said, well, are there actually behaviors which may not only be the result of the disease, but also may be the cause of the disease? And this is an exciting new area that I wanted to talk about a little bit, because it's another way to empower our patients, not only in terms of their behavior, but maybe also in terms of improving their vision in the future. So we just looked at this in several ways. Mediation analyses, others have looked with animal data and other studies as well. So we did a study where you actually look at whether the association between the outcome, which in our case we thought was physical activity, and the exposure, which was vision loss, is due to something which is in the middle, or a mediator. And when we looked at our macular degeneration patients, we found that people who had worse vision, in the sense of they had worse contrast sensitivity, did less physical activity. We suspected that this would go away when we added fear of falling into our regression model, and we found that it did. All of a sudden there was no association, and in fact it was slight positive association. However, when we looked at glaucoma, again there was a strong association between the degree of visual field loss and the amount of physical activity. But now when we added fear of falling into the model, that association didn't go away. In fact, it was still quite strong. Even if you add in driving cessation, again, it didn't go away. If you add in both, it doesn't go away. And so we've started thinking, well, maybe it's not actually fear of falling which causes the activity restriction, but maybe the activity restriction may even have a role in causing the visual field loss. In fact, Jonathan Crouston has found that if you exercise older mice and you subject them to a very high eye pressure, that you can preserve their response to a light stimulus, which is on the y-axis. It's the stimulus to an ERG response. And if you look at patients who were highly physically active as part of a national runner's health study, we found that people with glaucoma were less common amongst those who ran faster. And in fact, there were over 700 older men who had sometime in their life run a 10K in less than 41 minutes. And not a single one of them had glaucoma. Quite amazing. So I think the messages, in addition to what you've heard before, is that really glaucoma contributes substantially to individuals' ability to work, be independent, to read, and to move about. And we really need to measure this properly so we can communicate disease impact to others. We need to do more work to tease out the interplay between behavior and vision, particularly with regards to physical activity. And I would add as a final message, we really need to be using this information as we communicate with our funders, with our agencies, as we talk to patients, and as we work with other organizations to really encourage people to get proper eye exams and to get the proper care that they need. If anybody wants access to these slides, I'd be happy to share them, and my email address is right here. Thank you.